I'm Dr. Fakir Roberi, and this is bone and joint infections in adults. Bone and joint infections are a group of infections that affect various bones as well as joints, and occasionally if there is a hardware in place of a joint. These infections are generally complicated and often require hospitalization as well as long-term antibiotics, sometimes even lifetime antibiotic therapy to suppress the infection. Surgical interventions are key in source management. Nowadays, prosthetic joint replacement is used frequently to alleviate pain and of course to improve mobility. Unfortunately, these prosthetics devices can get infected, which can lead to significant morbidity. Prosthetic joint infections are often difficult to treat because the offending bacteria, often Staphylococcus species, form biofilm. Biofilm is essentially a polymeric matrix that allows single-cell bacteria to behave like multicellular organisms within the complex communities that they form within the biofilm. Inside the biofilm, these bacteria are protected from the host immune cells as well as antibiotics, because most antibiotics cannot penetrate the biofilm. A big exception is rifampin, which I'll explain shortly. The primary reason for the protection inside the biofilm is essentially the fact that there is no blood microcirculation inside the biofilm in order to deliver antibiotics and host defense cells. In addition to Staphylococcus species, Pseudomonas is also very capable of forming biofilms. There are several steps in the life cycle of a biofilm. Planktonic cells are essentially the bacteria that flow in the environment, and this environment could be the host, for example, the blood. The first step is for these bacteria to attach to a foreign object, oftentimes foreign hardware in the host. They can also do this occasionally with bone. The second step is irreversible attachment to the object by losing their flagella and producing biofilm matrix components. The third step involves maturation of cell clusters, which become several cells thick, embedded in the extracellular polymeric substance matrix. And then once the biofilm is fully mature, it provides this environment for these bacteria to grow, where they are protected from antibiotics as well as they have protection from the host immune cells. And the final step is the dispersion process, where these bacteria get released from biofilm, they regain their flagella, and they can continue to go back into the environment and infect other cells in the host. Osteomyelitis is a progressive infection that involves inflammation as well as bone destruction and new bone formation. It is generally classified into hematogenous osteomyelitis as well as contiguous osteomyelitis. Hematogenous osteomyelitis, which is often monomicrobial, it is more common in pediatrics. So 85% of the cases occur in pediatric patients. Hematogenous essentially means that the source of bacteria is from blood, so bacteremia leading to osteomyelitis. In adults, this could be due to injection drug use, central venous catheter. It usually affects the vertebra, which we refer to as vertebral osteomyelitis. For contiguous osteomyelitis, which is usually polymicrobial, it is either secondary to direct inoculation, often after trauma, surgery, or prosthetic implant, or it could be secondary to vascular insufficiency, especially spreads from surrounding soft tissue or ulcers to the bone. This is common in skin and soft tissue infection, especially in diabetic foot infection. Let's take a look at reliable resources. IDSA has several guidelines that are useful for osteomyelitis. The 2011 MRSA guidelines has a section dedicated to bone and joint infection specifically due to MRSA, so there are recommendations for that. There is also a 2013 IDSA prosthetic joint infection as well as a 2015 IDSA guideline for native vertebral osteomyelitis. And native basically means that the vertebra are the natural bones. There is no prosthetic devices involved. And lastly, because osteomyelitis often involves long-term antibiotics, there are recommendation guidelines from 2018 from IDSA for outpatient parenteral antimicrobial therapy, or OPAT for short. And of course, there is a IDSA guideline under development for bone and joint infections. The first learning objective is, given a patient case, differentiate between various bone and joint infections. Osteomyelitis is an infection involving any bone in the body or bone marrow. Osteomyelitis of the vertebra is specifically called vertebral osteomyelitis. Infectious arthritis is an infection of native joints that can be caused by bacteria, viruses, fungi, or parasites. Septic arthritis or bacterial arthritis are specifically bacterial infection of a native joint. And lastly, prosthetic joint infection is the infection of prosthetic joint, and its diagnosis depends on presence of a sinus tract that communicates with the prosthesis, as well as the presence of acute inflammation. And at least 2 intraoperative cultures or combination of preoperative aspiration and intraoperative cultures that yield the same organism. Now, if instead of 2 cultures, only 1 culture grows an organism, but it is a virulent microorganism such as Staph aureus, that also constitute diagnosis of prosthetic joint infection. By aspiration, I'm referring to basically when we draw fluids from the joint, so synovial fluid aspiration. We will focus on native vertebral osteomyelitis and prosthetic joint infection. Let's take a look at the clinical features. For native vertebral osteomyelitis, or NVO, there will often be back pain, tenderness of the spine, fever, as well as neurologic impairments, because this involves the inflammation of the spinal cord. Prosthetic joint infection, of course, involves joint pain and joint effusion, as well as fever, erythema, and warmth at implant site. For both of these, imaging is key. MRI is the most common one, but we can also use some other types of imaging. Now, when it comes to testing, there are non-specific biomarkers for inflammation specifically. So the most common one are ESR and CRP, so C-reactive protein and erythrocyte sedimentation rate. Now, you will see that CRP will increase and decrease faster than ESR. So ESR often lags behind CRP, but both of them are pretty sensitive. And of course, the white blood cell will also be increased. Now, keep in mind that CRP is elevated after surgery and returns to normal within weeks. Therefore, serial post-operative measurements are more informative than a single value. And for prosthetic joint infection specifically, diagnostic arthrocentesis is very helpful, and this is where we get synovial fluid analysis. Blood cultures are important for both of these infections, as well as baseline ESR and CRP, and imaging with MRI or alternative scan. For NVO specifically, CT-guided drainage of abscess is very important for source control. Synovial fluid analysis can be used to distinguish between septic arthritis, which is infectious, to distinguish that from non-infectious inflammatory arthritis, often due to gout. And the way you can distinguish between septic arthritis and inflammatory non-infectious causes such as gout is that, for example, when you get a culture of the synovial fluid, obviously nothing will be growing in a non-infectious cause, but it will often be positive. For example, Gram stain will show something preliminary for septic arthritis. Another thing you can look at is glucose. So you can see that the glucose levels in the synovial fluid is often greater than 25 milligram. But because if there are bacteria growing in it, they will be using the glucose as food in order to grow. The glucose levels will be low if there is an infectious cause for the arthritis. Another thing you can look at is the PMNs or SEGs. Normally there should be less than 25% segs in the synovial fluid. In an inflammatory process, there will be greater than 50%, but if it's due to infectious causes, it's often more than 75% of the white blood cells in the synovial fluid. And of course, you will remember from week 1 that neutrophils basically for the most part are segs. Another word for it are PMN or polys. And then so these are the mature neutrophils, and the immature neutrophils are called band cells. So the number of mature neutrophils will actually go above 75% of white blood cells in the synovial fluid. We differentiated between various bone and joint infections. Now let's list common microorganisms associated with vertebral osteomyelitis or prosthetic joint infection. Osteomyelitis is the infection of any bone in the body. Vertebral osteomyelitis is in general more severe compared to other types of osteomyelitis, specifically because it can involve the spinal cord. Now, prosthetic joint infection is relatively more severe than vertebral osteomyelitis because it can lead to septic arthritis, which can sometimes be deadly. Now, this is generally speaking. There are situations where vertebral osteomyelitis can be very serious and an emergency. Regardless of the severity, let's take a look at the common organisms causing vertebral osteomyelitis. By far, the most common causes of vertebral osteomyelitis include Staphylococcus aureus, Escherichia coli, and Coag-negative staphylococci. Now, because vertebral osteomyelitis is often hematogenous osteomyelitis, bacteria that commonly cause bacteremia can lead to vertebral osteomyelitis, such as streptococci, enterococci, pseudomonas, as well as non-E. coli enterobacterales. Now, for prosthetic joint infection, the common organism by far is the Staphylococcus aureus, causing majority of infection, followed by Coag-negative staph, and this is because of their propensity for forming biofilm, followed by streptococci, gram-negative organism, as well as enterococci and anaerobes. In fact, as a general rule, all microorganisms can cause prosthetic joint infection because of the presence of a foreign object in the body. We differentiated between various bone and joint infections. We listed common microorganisms associated with vertebral osteomyelitis or prosthetic joint infection. Now, given a patient case, select effective drug therapy for treatment of bone and joint infection. Let's start with native vertebral osteomyelitis. The goal of therapy is eradication of infection, restoration of function, and pain relief. The 2015 IDSA guidelines recommend that for patients with normal and stable neurologic examination and stable hemodynamics, it's actually recommended to hold empiric antimicrobial therapy until microbiologic diagnosis is established. What I mean is that you can order the cultures and then you can actually wait for the results of the cultures to come back and hold off antibiotics for as much as 1 to 2 weeks. Now, in patients with neurologic compromise, for example, those who have paralysis because the spinal cord is involved, it is recommended to make immediate surgical intervention as well as immediate initiation of empiric antimicrobial therapy. So what this means is that we should still attempt to get cultures, but we do not have to wait for the culture results to come back. So we can actually start empiric therapy based on suspected organism. And in patients with hemodynamic instability, sepsis, septic shock, or severe or progressive neurologic symptoms, it is recommended to initiate empiric antimicrobial therapy in conjunction with an attempt at establishing a microbiologic diagnosis. In other words, if it's taking a long time to get the cultures, it's recommended to not hold off antibiotics and go ahead and give antibiotics before we can even get cultures in patients. So how do we initiate empiric therapy for native vertebral osteomyelitis? It is recommended to cover MRSA, streptococci, and gram-negative bacilli. And keep in mind that common organisms are MRSA, E. coli, and Coag-negative staph, as well as streptococci species. IDSA panel specifically said that they are not in favor of routine use of regimens that cover anaerobes or fungal, brucellar, or mycobacterial organism because these pathogens are not as common. Now, the options that they did recommend include vancomycin plus a third generation cephalosporin. So the vancomycin will cover MRSA as well as streptococci, and then a third generation cephalosporin such as ceftriaxone will take care of the gram-negative bacilli as well as streptococci. Now, if your third generation cephalosporin is ceftazidime, for example, then it covers pseudomonas, whereas ceftriaxone does not. So in general, if the patient does not have risk factor for pseudomonal, it's not really necessary to cover it. Now, if you suspect that your patient can actually have pseudomonal infection, then a vancomycin plus a fourth generation cephalosporin like cefepime would be recommended. Unless you're using ceftazidime as a third generation cephalosporin, which would cover pseudomonas empirically. And of course, if you suspect multi-drug resistant pseudomonas in your patient, then your option would be carbapenem, with the exception of ertapenem, because ertapenem does not cover pseudomonas. And for those who have anaphylactic beta-lactam allergy, we can replace beta-lactams with fluoroquinolone, as well as those who cannot tolerate vancomycin, they can actually receive daptomycin instead. Now keep in mind that early switch to an oral regimen may be safe provided that C-reactive protein has decreased and epidural or paravertebral abscesses of significant size have been drained. So basically that will indicate source control. Now once the culture results come back, then it's important to switch empiric therapy to pathogen-directed therapy. And here are the recommendations for specific pathogens. For MSSA, nafcillin, oxacillin, and cefazolin are drugs of choice, as well as for osteomyelitis specifically, ceftriaxone has been compared to oxacillin and was shown to have equivalent efficacy. And the reason ceftriaxone is listed here, even though it's broader in spectrum of activity, is that because for osteomyelitis we have to treat patients long term, some of these patients may have to go home on IV antibiotics, and the convenience of ceftriaxone is that it is administered once a day. So that would make it ideal for outpatient therapy. Whereas cefazolin will have to be dosed every 8 hours in someone with normal renal function, and oxacillin and nafcillin will be dosed every 4 to 6 hours. Alternatively, if the patient cannot tolerate the first choice, the alternative recommendations are vancomycin, daptomycin, linezolid, levofloxacin plus rifampin, as well as clindamycin. And these are alternatives because the first choice are more effective as well as safer. Now, the reason levofloxacin and rifampin is a 2-drug combination is because that is how this combination was studied in clinical study. Now, for MSSA specifically, beta-lactams are superior to vancomycin, so it's always important to not use vancomycin for MSSA unless the patient had severe type 1 beta-lactam allergy, because by far beta-lactams are superior in eradicating MSSA. Now, when it comes to MRSA, that's when vancomycin becomes drugs of choice, because most beta-lactams are not active against MRSA, and ceftaroline, which does have activity against MRSA, has not been extensively studied for osteomyelitis. So vancomycin is very safe and effective for osteomyelitis due to MRSA. Now, alternatively, we also have the option with daptomycin, linezolid, and of course the combination of levofloxacin and rifampin. For enterococcus that's penicillin susceptible, either penicillin or ampicillin is drug of choice. And of course, alternatively, we can use vancomycin, daptomycin, and linezolid. Penicillin susceptible enterococcus is unlikely to be vancomycin resistant. However, when it comes to enterococcus that is penicillin resistant, it sometimes can be also resistant to vancomycin. At that point, daptomycin and linezolid become drug of choice. Otherwise, if enterococcus that's resistant to penicillin is susceptible to vancomycin, vancomycin would still be the drug of choice. For pseudomonas, cefepime is the drug of choice. Of course, if we're talking about multi-drug resistant pseudomonas, then carbapenems might be the option, because this could be resistant to cefepime or piptazo. The reason piptazo or piperacillin tazobactam zosyn is not listed here is because these agents have more extensively been studied for this indication of osteomyelitis. And compared to cefepime, piptazo has significantly less bone penetration. Now, for Enterobacterialis, Cefepime or erdapenem have extensively been studied, and there are drug of choice, even though cefepime is very broad spectrum. Because of extensive data for its efficacy is listed here, and alternatively we have ciprofloxacin. For beta hemolytic streptococci, we have penicillin and ceftriaxone as first choice, and vancomycin will be an alternative. And you can see the first choice for some of the other or causative pathogens. For Brucella species, which is extremely uncommon, the only two options are combination of either doxycycline and streptomycin, or combination of doxycycline plus rifampin. In particular, pay attention to the duration of therapy, because Brucella species, although uncommon, they are rather more difficult to eradicate, so often a very long duration of therapy is recommended. For native vertebral osteomyelitis specifically, total duration of 6 weeks of parenteral or highly bioavailable oral antimicrobial therapy for most patients with bacterial NVO is recommended. Of course, a total duration of 3 months of antimicrobial therapy is recommended for patients with NVO due to Brucella species. The rationale behind the prolonged duration mostly stems from the limited bone penetration of most antibiotics in patients with NVO, the need for several weeks for bone to revascularize following surgery, and the limited experience derived from trials in pediatric patients with hematogenous long bone osteomyelitis. Now, for prosthetic joint infections, the goal of therapy is, of course, to cure the infection and prevent recurrence, but also to ensure a pain-free and functional joint. The use of antimicrobial agents alone without surgical intervention is often unsuccessful because of the presence of a foreign object. Source control becomes extremely important. Therefore, the goals are best achieved by a multidisciplinary team of orthopedic surgeons, infectious disease specialists, a clinical microbiologist, and of course a pharmacist. Now, for prosthetic joint infections, source control is extremely important, so surgical intervention is key. However, some patients may not qualify and may not be a candidate for operation. If so, those patients may need long-term antimicrobial suppression because of lack of source control, and sometimes this could be lifetime. However, those who do qualify to receive surgical intervention, resection arthroplasty can either occur as a 1 or 2 stage exchange. In 1 stage exchange, basically the hardware is removed and replaced with the new one in the same procedure. In a 2 stage exchange, in the first phase, the hardware is removed and then followed by a period of systemic antimicrobial agents to make sure that the area is not contaminated, so that when the new device is replaced, the new device does not get contaminated. Now, during that period that the patient is getting systemic antimicrobial agent, a spacer which is impregnated with antimicrobial is placed, just because the hardware has been removed and there's going to be a space in there. So there will be a spacer in place until the second stage where a new hardware is placed permanently. And typically, the way that it's decided whether the hardware should be removed or not has to do with the duration of symptoms. So typically, if the symptoms are greater than 3 weeks, or if the hardware is actually older than 30 days, then it's actually removed and replaced with a new one. Otherwise, if the symptoms have been less than 3 weeks or if the hardware is pretty young, less than 30 days, debridement and retention will likely be enough. Now, antimicrobial therapy for prosthetic joint infection is pathogen specific rather than empiric. And what that means is that the antibiotics are actually selected based on the culture that we receive. And there are 2 ways to receive cultures. So if there is a diagnostic arthrocentesis performed, that's when we get synovial fluid and we can actually culture, and based on the results we can choose antimicrobials. Or if the patient requires surgery, during surgery tissue samples may be collected and then sent to the microbiology lab for culture, and then based on the results we can choose antibiotics or any antimicrobial that's needed. Now, for patients who get debridement but they have retention of the prosthesis, long duration of antibiotics are needed because with the retention of prosthesis, the biofilm will be present. Now, for prosthetic joint infection due to Staphylococcus aureus, so either MSSA or MRSA, which would be based on the results of the culture, IV antimicrobial therapy is absolutely essential for initial therapy. And this has to be in combination with rifampin because of the risk of presence of biofilm. And what rifampin will do is that will actually help dissolve the biofilm that would allow for both the rifampin and whatever we use for MSSA and MRSA to penetrate the source of infection, which is on the prosthesis. And this combination will actually have to be continued in the patient for 2 to 6 weeks. Rifampin is only available as PO, so the rifampin portion will be oral, whereas for the coverage of MSSA or MRSA, it has to be IV antimicrobial therapy because we want excellent bioavailability of these antimicrobials. And then once the 2 to 6 weeks, and the 2 to 6 weeks is decided based on how the patient progresses, we can basically trend CRP, C-reactive protein, and based on the patient's response, we can decide how many weeks is needed. But regardless, beyond the 6 weeks, the patient needs to be switched to oral antimicrobial therapy for a certain duration of time. And that depends on the type of arthroplasty that the patient receives. So either total hip arthroplasty or total knee arthroplasty. So the knee would require 6 months of oral antimicrobial therapy, whereas the hip would require 3 months. And for this phase, we want antimicrobials that are extremely bioavailable. So fluoroquinolones are by far the most bioavailable antibiotics. So ciprofloxacin or levofloxacin would be the drug of choice. Now, this is assuming that the culture results show susceptibility, so they must be susceptible. So sometimes ciprofloxacin is not excellent for MSSA. Levofloxacin is more likely to have coverage against MSSA. And then second line agents include trimsulfa, minocycline, doxycycline, cephalexin, and dicloxacillin. So if this happens to be MRSA, we may need to use one of these second agents that are active against MRSA. So trimsulfa, minocycline, doxycycline are typically active against MRSA. Now, if the patient cannot tolerate rifampin, whether because of allergy or toxicity or intolerance, and I should disclose that rifampin is a strong inducer of CYP3A4, so there may be drug interactions preventing the patient to take it. At that point, the IV and antimicrobial therapy for the empiric therapy would actually have to be at least 4 weeks instead of 2 to 6 weeks. So it would be 4 to 6 weeks as monotherapy. Now, for patients who need indefinite chronic oral antimicrobial suppression, the options include, oral options include cephalexin, dicloxacillin, trimsulfa, minocycline based on in vitro susceptibility. And this may be necessary for patients who cannot get arthroplasty or amputation, either because they're unsuitable or because sometimes they refuse to get amputation or arthroplasty. And I should emphasize that rifampin monotherapy is not recommended. It is never appropriate to use rifampin monotherapy for staphylococcal infections because when we use rifampin as monotherapy, staphylococcus develops resistance to rifampin very quickly. Now, for prosthetic joint infection due to other organisms other than staphylococcus, it does not have to be IV therapy for empiric treatment. So it can either be IV or highly bioavailable oral antimicrobial therapy for 4 to 6 weeks based on the culture results. Now, the treatment that I have discussed so far was assuming that the patient actually received debridement and retention of the prosthesis. Now, if the patient receives resection arthroplastic with or without reimplantation, This basically means that the source of the infection is removed, so all of the biofilm is removed. So for these patients, revamping is not needed because there is no biofilm. By resection, basically the source has been removed. And then the pathogen-specific IV or highly bioavailable oral antimicrobial therapy will be needed for 4 to 6 weeks. And for patients who receive amputation, these are the patients who receive the maximum amount of source control. And the way that we find out that if they received the absolute complete source control is that we actually wait for culture results 24 to 48 hours after imputation. And this is basically a culture from residual infected bone and soft tissue. So whatever tissue they actually remove surgically, from the margins, they would actually take a sample and culture to see if the margin around the area after amputation is actually infected or not. So antibiotics can be discontinued after 48 hours if nothing is growing. If something does grow on the margins, then antimicrobial therapy based on the culture results are needed for 4 to 6 weeks. We differentiated between various bone and joint infection and listed common microorganisms associated with vertebral osteomyelitis or prosthetic joint infections. We selected effective drug therapy for treatment of bone and joint infections. Now, let's avoid drugs that lack bone penetration for treatment of osteomyelitis. In general, oral beta-lactams have low bioavailability and should not be prescribed for the initial treatment of native vertebral osteomyelitis. Also, oral vancomycin is not absorbed and therefore it should not be used to treat any systemic infection. The only time oral vancomycin is indicated is for C. diff infection or Clostridioides difficile infection, which is in the GI tract. Now, on the other hand, antibiotics that have excellent bioavailability include fluoroquinolones such as ciprofloxacin, levofloxacin, and moxifloxacin, as well as linezolid and metronidazole. And these allow the possibility of early switch to the oral route without compromising efficacy. Here's a list of drugs that are excellent oral options because of their excellent oral bioavailability. Metronidazole is specifically used when there is osteomyelitis due to Bacteroides. So Bacteroides are anaerobic organisms. Moxifloxacin is not indicated for staphylococcal NVO, but it can be used for Enterobacterales. Linezolid is an excellent PO option for MRSA NVO. Levofloxacin is also used for Enterobacterales, and ciprofloxacin is excellent for pseudomonal infections. Bactrim or trimsulfa is not recommended for staphylococcal NVO, but it can be used as second line for Enterobacterales, and clindamycin is considered second line choice for staphylococcal NVO. And as I mentioned previously, for brucellar NVO, the combination of doxycycline and rifampin is an excellent oral option. Here you can compare different antibiotics and what percentage of the dose will actually penetrate the bone. There's no magic number of what percentage would be ideal because these antibiotics are given at different doses, so these percentages are not really comparable, but it kind of gives you a sense of how much of the dose that's given to the patient actually makes it to the bone. Now, ceftriaxone, it's really important to keep in mind that the usual dose of ceftriaxone is 1 gram once a day. Because of its poor bone penetration, typically less than 20% of it gets to the bone, so it is recommended to use a higher dose of 2 gram once a day when it comes to osteomyelitis. Now, some of these agents like daptomycin may seem like they are a poor option for osteomyelitis, but considering that we give a very large dose of these antibiotics like daptomycin, even that small percentage that gets to the bone is going to be a huge concentration of daptomycin. So everything listed in this table is actually an excellent option for treatment of bone and joint infection. Now, keep in mind that the dosing that's recommended by the guideline for inpatient and compare that for outpatient. So if the patients require weeks of antibiotics, they're not going to stay in the hospital for 4 to 6 weeks, so they actually can go home on some of these IV agents. And you will see that, for example, if a drug is given, several times a day, one way to convert that into a once a day dosing is to give a continuous infusion. So what continuous infusion or CI means is that you will give the entire dose for the entire day. You basically infuse it over a 24-hour period. So you basically change the bag every 24 hours. So by doing this strategy, you achieve two things. One thing is that for beta-lactams specifically, because they are time dependent, you maximize the time above MIC. And the second thing is that you essentially convert this regimen into a once a day dosing, and that makes it easier for outpatient management. It is also important to note that ampicillin as well as carbapenems, basically meropenem, imipenem, doripenem, these drugs are not suitable for outpatient continuous infusion because of their short stability. So meropenem, imipenem, doripenem, these drugs typically are stable for 4 hours. So if you were to do continuous infusion over 24 hours, basically the bags needs to be changed every 3 to 4 hours, which makes it extremely difficult to do continuous infusion. Even in patient, it's very challenging to give carbapenems as a continuous infusion. Erdapenem, of course, is an exception because it's actually dosed once a day. So it's really not necessary to convert it to continuous infusion because it's similar to ceftriaxone, is dosed once a day. So it's really convenient for outpatient. So here you can see that it's recommended to avoid carbapenems other than erdapenem for outpatient if possible because of stability issues. We differentiated between various bone and joint infections and identified microorganisms associated with these infections, and given a patient case, we selected effective drug therapy for treatment of bone and joint infections along with total duration of therapy. Now, given a patient case, let's develop a monitoring plan for antimicrobials used in the treatment of bone and joint infections. The 2015 IDSA guidelines for native vertebral osteomyelitis recommend monitoring systemic inflammatory markers, specifically ESR or CRP, after approximately 4 weeks of antimicrobial therapy. If after 4 weeks of treatment with antibiotics, ESR and CRP are unchanged or worse increasing, then there should be a suspicion for treatment failure. When it comes to imaging, it is not recommended to have in general routine follow-up MRI. Unless there is a need to assess evolutionary changes of epidural or paraspinal soft tissue in patients with NVO, or in patients who have poor clinical response to antimicrobial therapy. Here's a list of IV antibiotics that are used outpatient for the treatment of bone and joint infection. Rifampin is also available as oral, so it is often used orally for the treatment of bone and joint infection. Keep in mind that according to the 2018 IDSA guidelines for OPAT or outpatient parenteral antimicrobial therapy, it is recommended to check CBC and so complete blood count and basic metabolic panel weekly for outpatient monitoring for all of these agents. For some of these agents that are more likely to assault the liver chemistries are also recommended to be monitored weekly. And of course, nafcillin, ceftriaxone, and rifampin are not renally adjusted. Now, on this list, every agent is available as oral formulation with the exception of vancomycin and daptomycin. So vancomycin and daptomycin must be given as IV for the treatment of bone and joint infections. Again, for most of these agents, IDSA recommends a weekly monitoring of CBC and BMP. And for some of them, you also need liver chemistries. And for vancomycin, it is also recommended to check a weekly vancomycin trough. And for daptomycin in particular, it is recommended to check a CK or creatinine phosphokinase weekly. And it is recommended to discontinue daptomycin in symptomatic patients with a CK of more than 1,000, or if they're asymptomatic but their CK is more than 2,000. And 2000 would basically be equivalent of 10 times upper limit of normal, and 1000 would be equivalent to 5 times upper limit of normal. And this is because this increase of CPK due to daptomycin can increase patients' risk of rhabdomyolysis. So these symptoms would basically be muscle ache and other symptoms of rhabdomyolysis. Now, in particular, moxifloxacin and doxycycline as well as linezolid do not need to be renally adjusted. Now, what exactly is outpatient antimicrobial therapy, or OPAT? According to IDSA, OPAT is defined as the administration of parenteral antimicrobial therapy in at least 2 doses on different days without intervening hospitalization. And the use of OPAT can significantly reduce hospital stays when oral therapy is not an option. Now, parenteral antimicrobial therapy is traditionally offered in an inpatient setting. However, outpatient delivery of antimicrobial therapy has increasingly been used to facilitate early discharge from the hospital. The goal of OPAT programs is to provide the required infrastructure for optimal patient selection, monitoring, and treatment, and to enable patients to complete IV therapy safely and effectively in one of the outpatient settings. Many studies have confirmed the safety of OPAT with appropriate antimicrobial selection and monitoring while reducing the risk of healthcare-associated infections. Patients with recent histories of injectable drug use are generally not considered candidates for OPAT because they may use vascular access devices to inject drugs. For these patients, we may consider long-acting antibiotics such as dalbavancin, which can be injected once weekly, eliminating the need for vascular access devices in these patients. IDSA guidelines make no recommendation whether people who inject drugs may be treated with OPAT at home. Decisions should be made on a case-by-case basis. For patients who qualify for OPAT, OPAT can significantly increase quality of life, allowing them to participate in most normal daily activities while completing treatment. Patient education is crucial. Because extended treatment duration is common, patients need to understand the importance of adherence to the selected treatment and monitoring plan, as well as the associated toxicities they should report to the healthcare team. This concludes this presentation.